It's a great pleasure to be with you all today over in the West Coast, and I'm talking to you from Toronto. Miracle of technology, but yeah, this has been a very challenging time for all of us across the world, but things are looking up, and certainly in Ontario as well. So I'm going to be talking to you today about preventing and treating depression as we age. And these are disclosures just to say that I don't have relationships with any commercial interest today, that I'm chair of the Coalition's Guidelines Committee, and we've been funded by Health Canada to create guidelines. And I'm also a member of the leadership team for something called the Fountain of Health project that I'll be talking about today, a little bit about, and a project that we did looking at certain tools that could be used by clinicians to promote health amongst their patients. So this is what I'll talk about today, a little bit about happiness and aging, how we can achieve optimum mental health, some guidelines regarding the recommendations on preventing depression, the Fountain of Health approach, and then guidelines around the actual treatment of depression. Well, Mark mentioned the pandemic, and this is hot off the press. This is an amazing article that came out in Lancet just a couple of weeks ago. The investigators were able to get data on the degree of depression and anxiety across the world during the pandemic. I don't know how they managed to get all this data, but it shows that in virtually every country in the world there's been a significant increase in depression and anxiety, not surprisingly. And overall, about a 25% increase in both of those. And this, from the same article, shows the degree of depression and anxiety by age group. And of course, that depends on the population as well. But basically, the wider those bars are, the more depression and anxiety there is across the population. But the colors orange and purple show the increases that have happened during the pandemic. And interestingly enough, of course, it's actually younger people who really seem to be suffering the most in this regard. And there has been a fair bit written about the resilience of older adults during these difficult times. That being said, we know that there's been a huge amount of increased isolation and loneliness and depression amongst seniors. So we're all striving to be happy, and that seems like a tall order in some circumstances, but even if we have moments of happiness, that's pretty good. Interestingly enough, there are studies showing that as we age, we're actually more likely to be happy. Isn't that surprising? There's some studies from San Diego and California where they looked at different age groups, and they actually found, this is really interesting, that although one's physical health naturally declines as we age, the overall sense of well-being actually increases, gets better over time, which seems kind of strange. The researchers come up with different theories about this. One is that older adults may expect life to be harder and to learn to live with it, or they're actually more realistic about their goals, only setting ones they know they can achieve. And another investigator, Carstensen, thinks that with time running out, older people have learned to regulate their own emotions, focusing on the things that make them happy and letting go of those that don't. Interesting. Sasson writes about positive thinking, and these are some of the things you can do to think more positively and to do good things. So look at the bright side of life, have faith in yourself and the power of the universe, associate with positive people. You don't want too many friends who are downers. Read inspiring stories, repeat affirmations that inspire and motivate, visualize only what you want to happen, and learn to master your thoughts. Meditation, mindfulness, these things are all good things and can help us feel better. But what if you do start to get depressed? So there are different diagnoses we use. The big one is called major depressive episode. That's when you've got a significant depression, not just depressive feelings. And then there are, on the right-hand side, there are other conditions that are less severe, by and large, usually, although not always. And so adjustment disorder, that means that something bad's happened in one's life and you have some depressive feelings, but it's possible to get over that without any kind of treatment. And of course, bereavement itself, which is so frequent as we age, has its own challenges and may evolve into a depression. So these are the things we actually look out for when we're thinking that somebody might have a significant depression. So apart from depressed mood itself, we look for anhedonia, which means loss of pleasure, the inability to experience pleasure, changes in sleep, usually challenges sleeping, less sleep, but sometimes more. Same with appetite. Most people lose appetite, but some people actually have excessively increased appetite when they're depressed. Low energy, poor concentration, feelings of guilt or worthlessness, being really slowed down or restless and agitated. And then, of course, when someone's really seriously depressed, they may actually have thoughts of death or suicide. And these symptoms, you don't need all of them, but if you have 5 out of 9 for at least 2 weeks, we would start to think the person might have a significant depression that might need some sort of help. We're always trying to think about, so why is someone getting depressed? Is there a reason for it? Is there no reason? In fact, some people may actually just get depressed for no obvious reason. At the bottom it says just depressed, don't want to analyze it. But we know that as we age, there are stressors. There are things that are more likely to happen that could contribute to depression. So increased physical illness, chronic pain, sensory deprivation, so losing our vision or our hearing, the actual life changes that retirement brings. Retirement can be wonderful, but for some it can be a really difficult period. Bereavement, social isolation, loss of roles and status in society, and then financial difficulties that are very common as we age. So all of these are stresses that could contribute to depression. In our fields, we like to think of what's called a biopsychosocial model, which means that we don't think there's a single cause for depression, let's say. There might be biological causes, which are more physical in nature and could include changes in the brain or in the body or chronic illness, drug issues. And then there are social, environmental factors that could seriously bring down our mood, as well as psychological factors. So when we teach our trainees, our residents in psychiatry, this is the model we teach them, that they have to think about not a single cause, but really try and understand the person both in the past, in the present, in terms of all of these different factors. And we're always striving, of course, for mental health. And even people who have suffered from, say, chronic mental illness, we can improve their mental health in many different ways. So recently, our coalition, the Canadian Coalition for Seniors Mental Health, revised our guidelines. These are guidelines for health professionals on how to prevent, assess, and treat depression among older adults. So this document is available, if you have any interest, online at the website of the coalition, which is at the bottom there, www.ccsmh.ca. And you can, download or look at the whole document if you're interested. But more likely you'd be interested in some of our other resources that are on the website that are specifically designed for older adults and their families and the general public. So, and there are such materials for a whole variety of different conditions, including depression. So within those guidelines, these are the things that you could find. And going to focus more on the ones in red, so how to prevent depression, and then some of the interventions, whether they be psychosocial or pharmacological. There are lots of people to acknowledge regarding these guidelines, as listed here, particularly Health Canada, lots of people. This is the guideline update group, and I have to shout out to Laurie Amdam, who's been working with the coalition as a volunteer for many years and is on Vancouver Island. She's a wonderful person, and as well as other colleagues from across the country. And actually, this was the group that put together the original guidelines 15 years ago. So we always acknowledge them as well. So these are the actual recommendations on preventing depression in these guidelines. So there's actually 5. One is to reduce isolation and loneliness. I'll mention what a stepped care approach means. Something called social prescribing, increasing physical activity. I'm sure you've never heard that one before. And then this is for health professionals, that we need to always instill hope and positive thinking when we're caring for individuals, whether they have a mental health or a physical problem. This is the actual wording of the guidelines recommendations. So it says that there are many interventions that focus on reducing social isolation and loneliness. And these have been studied and have been shown to reduce depressive symptoms in addition to reducing loneliness. And a lot of these interventions are group-based, interestingly enough, and there are all sorts of therapies and physical exercise programs and so on and so forth that have been studied and actually shown to reduce the likelihood of people getting depressed. Stepped care is for people who have some depressive symptoms, not an actual illness, but it involves gradually introducing certain interventions depending on how severe the symptoms are. And this has been studied actually in various countries, including the Netherlands, and it's been shown to reduce the ultimate development of depressive or anxiety disorders. And then there's something called social prescribing, which is being trialed now in many countries, including Canada. And this is actually where instead of prescribing medication, the physician or other healthcare professional actually prescribes contact to the voluntary or community sector, the resources in the community. And this has been studied and shown to be beneficial. With guidelines, we're always looking for evidence, research evidence. So we only make recommendations if there's some evidence to support it. And then, higher levels of physical activity are consistently associated with lower odds of developing depression in all age groups. So this has been well studied, and it doesn't have to be, rigorous aerobic activity. Walking is a terrific physical activity if you're able to do that. Even stretching exercises are fantastic. And then finally, as I mentioned before, it's always important for us to instill hope and positive thinking as a therapeutic tool. So I want to talk a little bit more about prevention and risk factors. And although I'm talking about depression, there's a big overlap with dementia and depression, so Alzheimer's and other dementias. So there's a huge movement right now to try to maximize these modifiable or actually maximize the reduction of these risk factors. And if you look at the 9 listed here, a lot of them are physical things that we need to do to maximize the health of each person. Again, physical inactivity is on the list, but depression is also on the list. So identifying and treating depression is also a way of actually preventing dementia, believe it or not. So this is really important. So the Fountain of Health project originated in Nova Scotia and was the brainchild of a colleague of mine, Dr. Carrie Lee Cassidy, who's a geriatric psychiatrist. And with her team in Nova Scotia, they developed this wonderful program called the Fountain of Health. And playing on the term, the Fountain of Youth, of course, but the website is there. There's all sorts of great materials on the website. for the general public and for clinicians. And this is a way of helping people to make positive lifestyle changes to improve their health. So these are the next few slides are actually from the Fountain of Health. So consider this: what non-pharmacological treatment improves the outcomes in heart disease, hypertension, diabetes, arthritis, depression, anxiety disorders, obesity, addictions, and insomnia, and is the #1 most powerful promoter of brain neuroplasticity? That's creating new connections within our brains, which can occur at any age. And what's the single best thing we can do for our overall health? Well, the answer is exercise, increasing physical activity. So the Fountain of Health really promotes the idea that there are a lot of things we can do to improve our health. And the question, one important question, is to what degree do we control our own health destinies? And this might surprise you, but genes only account for about 25% of what determines human longevity. Only 25%. I always thought it was more, but twin studies have carefully looked at this and shown that it's only about 25%. So this is really good news. It means that there's more under our own control. So the Fountain of Health recommends 5 key domains. So positive thinking, social activity, physical activity, challenging our brains, and promoting mental health, recognizing when we have issues and doing something about it. And the approach is simple. You get a baseline, you set one goal, and then you track your progress. So it's a very simple behavioral approach. Getting the baseline, these are questionnaires that are online, or your doctor or healthcare practitioner could give them to you if they're using the Fountain of Health. And there's also an app, which I'll mention in a minute, that you can use if you're tech savvy and use cell phones. A free app, of course. And the goal of setting a SMART goal is really important. What's a SMART goal? Well, it's specific, measurable, meaningful, action-oriented, realistic, and time-limited. So when are you going to do it? And, you know, it's all very well to say I'm going to exercise more, but unless you actually do this, where you actually write down what you're actually going to do, how you're going to measure it, you know, what's the specific action that's required? Is it realistic? Is it, you know, when are you going to start? If you don't do those things, it's just theoretical. And this is not easy. Changing our habits is really quite difficult. And I for one, I should exercise more. You know, definitely. I know I should. And I do my best to follow these things, but I'm not always successful. So I know it's hard, but it really can make a change if you follow the simple approach. And you know, ultimately, you set a goal, simple goal, track it, see how you're doing, and then if you achieve that goal, you can set another goal, maybe one that's a little more challenging. And we actually encourage people to start with really small, attainable goals. We want to win. And this is how to actually find the wellness app. But you can get it right off the website, thefountainofhealth.ca. The project that we were funded for last 2 years ago was to try to get clinicians across Canada to start using these tools with their patients. And so it was a pretty big project, and we had some success. And but the hardest thing is also to get clinicians to change their habits, because many clinicians are not used to doing this kind of work around health promotion. So, so that brings us back to depression. So all of those things that I mentioned before, all of those things could benefit us in terms of preventing depression. So everything I've talked about up till now is actually really around preventing depression. I did mention before that there are different kinds of depression and different approaches. And so the guidelines that I mentioned go into all sorts of detail about, if you have this kind of depression, then we suggest this kind of approach and intervention and so on. But even before one gets there, as a healthcare professional, we have to make a diagnosis, and that involves an assessment. So what does that mean? Well, we always start with an interview, and that means getting to know the person, understanding their full history, which would involve their mental health history, if there is one, if they've had a previous depression or some other problem, anxiety, knowing about their physical health, knowing about their family history, what medications they're on, and so on. And that's really, really important, of course. And then in many cases, we want to get history from a family member or other caregiver as well, if possible. It's not always necessary, but for some older people, it really helps to get a collateral history, as we call it. And then we do what's called a mental status examination. We try to understand how the person thinks, how they're feeling, understand the way that they think, as well as a cognitive assessment, which means memory and other brain functions. So we use various tools to do that, often very quick tools that might be done in 10 or 15 minutes. That's important to us as well, to understand if the person's having any difficulties with memory or other cognitive problems. We might need to do a physical exam, not always, but if we're trying to rule out certain underlying physical conditions, that might be necessary. Usually we'll do some blood work, at least at the beginning when we're seeing someone for the first time, to rule out certain illnesses, like if your thyroid gland isn't working properly, if it's underactive, which is very common, that can cause depression. So we need to rule out any underlying physical condition, if at all possible. Low B12, vitamin B12 could also be a factor. In some cases, we'll do brain imaging, but not always, only if there's some real reason to do it. And then we always assess safety, including driving safety, which gets people nervous. In Ontario, physicians have to report someone to the Ministry of Transportation if they suspect the person may not be able to safely drive. And that's a whole other talk and a really challenging issue, and a really controversial area, of course. So so I did want to talk a little bit about how we actually treat depression. If someone has a significant depression, then what are the possible interventions? And so the first thing we like to think about is not medication. Again, we're talking here even if someone has a fairly significant depression, sometimes they don't need medication. They may well respond to talk therapies that we call psychotherapy, or other psychosocial interventions. So the guidelines emphasize that we don't always start with medications. So, and these are some of the, I've only taken a few of the actual recommendations, because it's quite a large document that has all sorts of different recommendations, but just so you can get a snapshot view of the kind of things that are in the recommendations. So this one says that there's actually promising evidence for exercise and mind-body interventions such as Tai Chi, yoga, mindfulness-based stress reduction in reducing depressive symptoms in late life, either alone or in combination with other therapies. Physical activity in the form of exercise is an important non-pharmacological approach. So not only is it helpful to prevent depression, but it can also be a treatment. So people who are depressed feel better when they exercise. And then clinicians should use their judgment in recommending the type of exercise and duration, taking into account other illnesses, physical capacity, and level of motivation. So There's a lot on that recommendation, but it's really important that clinicians consider this range of different interventions and make recommendations to their patients. And then it talks about the more conventional psychotherapies, and there's a whole range of different talk therapies. Probably the most well-known is what's called CBT, or cognitive behavior therapy, which can be for individuals or for groups. It can be, you can have group therapy using that approach. Another popular approach is called problem-solving therapy, PST. And so these particular types of therapy have been well studied in older adults and found to be very effective. So even for someone with a significant depression, a course of CBT could help them feel a lot better and may be quite effective, particularly if the depression is reasonably mild. And the guidelines actually say that these types of therapies should be made available to older adults with depression in diverse settings across all regions of Canada. So this is really an advocacy type recommendation, because often it's hard to find a therapist, especially one that's covered by the health plan in your province. So we make this recommendation, and we like to advocate for more services for older adults as part of what we do in the coalition. We mentioned that there are other therapies that have been studied and seem to work as well. And finally, we suggest that therapies can actually be delivered virtually through the internet. And there are studies showing that they seem to be, for some people, they may be comparable in effectiveness to face-to-face treatment. And of course, this improves access to services for individuals in underserviced areas and those with mobility issues. So, and of course, as Mark was saying at the beginning, the world has changed during the pandemic. And so virtual assessment, virtual care has become a mainstay for us during the pandemic. And many of us are now delivering a lot of our care and assessments virtually. Now, I've always done some virtual assessments. I consult to the far reaches of Northern Ontario, and I've been doing that for almost 20 years, which is, and that's using older technologies. But fortunately, we've been able to do that now for 20 years. So the fact that virtual assessments and care are now mainstream is really just catching up with what's been available for many years. And a lot of health professionals have suddenly, realized that this works, especially in areas like mental health, where most of what we do is talking. And then finally, we do talk about antidepressant medications, of course, and there's a lot of advice for clinicians about how to use medications, which ones may work, which ones, if the first one doesn't work, what do you do next, what medications you might need to combine. So there's a lot of detail in the guidelines about this. But just to say that we actually do recommend a couple of particular antidepressants as first line, but then we also say that there are many others that are also very good medications. And we give advice about, that for older adults, we always need to be aware of the potential for side effects and minimize the risks. And we don't want there to be drug-drug interactions. So that's really important and something that we strive to use. So we strive to use the lowest amount of medication possible and choose medications that are the least likely to cause side effects. Really important. And we stress as well that if someone's being started on an antidepressant, that they need to be seen regularly to assess their response, the side effects, to titrate the dose, and that in addition to medication, everyone needs support. supportive psychosocial interventions, as we call it, as well as monitoring for possible worsening or agitation and suicide risk. You may not be aware of this, but older adults, particularly older men, are very vulnerable to suicide and have very high rates of suicide. So that's something we're always very cautious about. We do make some recommendations about the models of care. This is for clinicians, so they understand that there are a number of things that we believe are really important. So collaborative, interprofessional care can be really helpful, particularly in primary care. There have been a lot of studies showing this. And so having a team approach can really help. And we recommend that, again, that going back to virtual care, that's fine, but we also suggest that this virtual care needs to be senior friendly, because some older adults really struggle with technology, and they need to be supported in this, and but not the group here tonight on Zoom, obviously. Finally, there are these resources that are available on our website, including in different languages. And you can join the Canadian Coalition for Seniors Mental Health for free. And if you do, you just sign up on our website. And if you do, you get all of our materials and updates, and we'd love to have you on board. It's not just for health professionals, it's for anyone who would like to help out in this area of seniors mental health. And Claire Checkland, who's in Ottawa, is our executive director. So thank you very much.